Michelle Andrews. I've been a nurse for 21 years and a nurse leader of varying capacity for the last 17. Most recently, I've had the opportunity to be the Chief Clinical Officer of a local long-term acute care hospital, which started as a Director of Quality position and expanded into a broader scope. Part of my responsibilities is to oversee the quality plan, program, and risk management and the clinical staff of our hospital. As nurse leaders, we deal with the quality in a variety of ways. Many functions, including audits, performance review, investigation, and regulation. My current role has heightened my understanding of the role of quality, safety, and regulations in a hospital. In fact, I found myself fascinated with the origin and development of standards, regulations, and quality expectations. Improving quality and decreasing risks are not new concepts in healthcare. Many of the policies and regulations implemented today stem from identifying the root cause of adverse effects, altering our practices appropriately. Since the time of Dr. Semmelweis, decreasing peripartum infection by introducing hand washing in between patients. While significant in their impact, improvements by individuals are focused on solitary practice, take time to institute throughout an organization or industry. It takes up to 17 years to move research to the bedside. That is not global nor nearly fast enough. Improving outcomes needs to be a daily instinctive activity, an activity in which every person participates. That's not a new concept either. In fact, I believe most healthcare organizations touch on this very idea in each of their mission statements. Because our goal is to do no harm and improve our care, we should be striving for a culture, not just a practice or rule, of patient safety. According to the Agency for Healthcare Research and Quality, the safety culture comes from other industries and their high reliability organizations. Organizations that keep adverse events consistently minimized despite carrying out intrinsically complex or hazardous work. These organizations maintain a commitment to safety at all levels, from the front line to the highest executive. The commitment establishes a culture of safety that incorporates acknowledgement of inherent high risk in the work and determination to achieve consistently safe operations, a blame-free environment where individuals feel comfortable, free to report errors or near misses, encouragement to work together, regardless of rank or department, to seek solutions to risk, and a commitment of resources to address safety concerns. The survey tool that assesses perception indicates that high perceptions of safety culture are conversely correlated with lower rates of error. Many reasons are attributed to the variability in the perception, which is a significant indicator of correlating error of a culture of safety, according to the AHRQ. Those include the sense of blame, poor communication, poor teamwork, a lack of commitment in individuals, and a lack of resources. In healthcare, the identification of high-risk nature is consistently understood. I believe we are saving lives. However, there are varying definitions of what is considered a high-risk procedure process when talking to different clinicians. Having investigated adverse events over the years, the amount of risk in medication administration is thought of differently depending on the nurse discussed with. But the real amount of risk in the process can be critical. The fear of getting into trouble creates another concern for the culture of safety. Performance is tied to practice, and errors in practice can result in intervention. So how do we create a non-punitive belief? Also, if there is concern of telling a supervisor or perceived superior about a witnessed event, rarely will it be pointed out. If an organization struggles with silos and interdepartmental separationalism, it is also at risk for poor culture of safety. Finger pointing across boundaries prevents an open and honest approach to a broken system versus a race to identify the department with the problem. So as a nurse leader, how do we overcome these concerns, issues, and enhance the culture of safety? I believe we need to eat, breathe, and sleep safety. In essence, we must be the role models and demonstrate the behaviors we want from all. And it starts with the interviewing process. Expectations must be clear and our message consistent. Risks associated with tasks should be outlined. Never should clinicians feel something is done as a policy regulation or because they require it. They should understand that the risks to the task at hand is A, B, and C. and a description of the outcomes presented. This is a part of education, policy development, review, and coaching. Like the surgeon should do risk, benefits, and alternatives to the surgery being performed, every level of clinician should appreciate his or her impact on the patient. Managing the fear of reprisal presents a greater problem for the leader. The best tool available is proactive review, trying to eliminate risk from the front end through the FMEA, focus group discussions, or case studies. All assist in teaching from errors without individualizing. However, when practice issues do occur, it is only fair for the clinician to be allowed a thorough investigation and feedback. So if all causes are removed and poor decision-making is the root, then a candid coaching counseling can happen without the sense of simple blame. Teamwork and communication will always require nurturing and role modeling. If a nurse leader points to another or doesn't interact well, then that is noticed and emulated. Also, I believe there are greater opportunities to walk a mile between departments. I've often had my staff in the past work in other departments so they could appreciate the pressure that others also feel. A heightened commitment of individual requires the highest leaders to be disciples. We cannot have evidence of do as I say, not as I do. And senior leaders need to be held to a stricter standard of measurement related to culture of safety, perhaps a larger percentage of performance rated on the staff perceptions. Financial resources are presently increased based on the changes in reimbursement and will most likely continue. So resources are being given to safety, but it's because of reimbursement issues. However, when an outlier is identified, the solution should not be delayed as the liability could be significant. All leaders have an impact on the culture of safety, but as nursing comprises one, if not the largest part of the workforce in many organizations, the nurse leader's placement of high level importance on culture of safety is imperative. Thank you.